Hi.
Hi. All right, I hope everyone had a nice long weekend. We're going to go ahead and get started. Is it starting? Okay. Yeah. All right, welcome everybody. This is our 5th ECHO session. I can't believe we are already more than halfway through. I hope everyone is settling in to back to school. So give me 1 second here. Why is this not? Give me 1 sec. Okay. All right. Okay, so just a reminder, folks, for roll call, as you join the session, please type your name and organization into the chat box. Today is going to be the first of 2 clinical care focused sessions. One of our expert faculty, Dr. Renata Arrington-Sanders, will be doing both of those sessions. The first of which is going to focus on taking an inclusive sexual health history. And then we're going to have one case presentation from Maureen Murphy in River Rouge, Michigan. So just to remind everyone about CEs, you must complete the evaluation that will come from a PHA about a week from now. The slides and the recording will be posted to Moodle by tomorrow. And if you have missed today's live session and you're watching this as a recording, you have until next Tuesday, September 10th to post a reflection on the reflection forum in Moodle. And as I mentioned earlier, since this session is a 2-part, it's the first of 2 parts, 2 sessions focusing on clinical care, you can only miss one of the live sessions of these 2 in order to receive CEs for this topic area. And then just another reminder, the midpoint evaluation has been posted to Moodle under the Welcome tab for a couple weeks now. Only a few folks have actually gone in and completed it. So I really need feedback from people. It's really important to see how you're benefiting so far from the ECHO. What kind of improvements can we make? I promise you it will take you no more than 3 minutes, and your feedback is really important. So please go on Moodle and complete that as soon as possible. Our slides are frozen.
Well.
Okay, bear with me for a second, okay. Oh wait, we're not sharing. I can't see. Hang on. Technology's being slow today. Okay, so case presentations, I think I've been in touch with most of you so far about signing up for a case presentation date. So I think we're mostly good with that. There's still a few more folks that I have not heard from yet. And a couple folks I've asked you to present for a certain month, but have not heard back from you yet. So please confirm with me. So I really want to finalize that as soon as possible. Okay, so as I mentioned earlier, our presentation for today is from Dr. Renata Arrington-Sanders, and I'm going to stop sharing and pass it off to her now.
Okay, thanks. All right, let me try this again. Okay, perfect. So today I'm going to focus on some of the best practices for taking an inclusive sexual history. There's going to be some information that Molly had presented earlier on that will be repeated, but I think it's important just to think about how you talk through that and how you speak to individuals when you're seeing them. There's a lot of stuff to do here, and so I wanted to make sure people had some good foundation. So we're only going to accomplish those. So really to think about strategies to effectively engage adolescents, and then also to really think about confidentiality protections for adolescent patients. I'll end by just talking about ways that you could engage and focus on adolescents that you're seeing in the school-based health centers or space health settings, and hopefully that'll be useful to you. I always like to start off with a case. So Erica's 16 years old. She's sexually active. She's a cisgender female. She presents to the school-based health center. She describes that she's attracted to females only, and she has had 2 male partners. So this is a good question because it really frames a lot of the key issues that we might talk about today. And I want you to start thinking about how would you approach Erica when you're seeing her in the school-based health setting. I'm going to go through some steps that I would suggest, and then we're going to also talk about the evidence around that as well. So the first step really is to create an inclusive environment. So this is a sign that we have posted here in the clinic. It's at every registrar's desk so that everybody knows that everyone is welcome and this is a safe environment. And this is supported by the American Academy of Pediatrics, which recommends that providers initiate and discuss issues of sexuality and create affirming spaces for all adolescents, regardless of their sexual orientation or gender identity. And to have sensitive and culturally appropriate signs that welcome all persons in that space and that it be visible. We also found in doing some work here where we surveyed youth, sexual and gender minority youth, that they felt like they wanted some other visual cues, not only at the front desk or at the registrar area, but also when they got back to see the provider, that the provider was comfortable, welcoming, and that the provider was accessible. So one of the things they described was having a name badge that had some sort of visual indicator that demonstrated that this provider actually got it, right? That this provider was actually supportive of LGBT patients. And so what you see here on this slide are 2 quotes from participants. I was apprehensive to tell doctors because I don't know how they could react unless it's clear, like they have a rainbow flag in their office or something like that. And so that just gives you an idea of how adolescents are thinking. Unless there's really a visual way to know that the provider that they're seeing is safe and accepting, they may not be willing to disclose certain information. The other sign that's shown here up in the corner is a safe space sticker that is actually developed and distributed by GLSEN, and we'll talk about that a little bit later on as well. Oops. So I think the second step is to routinely assess history. So there's been recent work that demonstrates that as providers, we really don't do a good job of asking and discussing sexuality and and gender identity or sexual orientation or sexual risk. And so this study surveyed pediatricians and found that 1/3 of them included no discussions around sexuality. And when they did, they only spent on average about 36 seconds. So that's not a lot of time to talk about critical issues. So we use the HEADS assessment, which you've probably heard of and are familiar with, to really go through a systematic approach of talking to adolescents. And it's an acronym for topics that providers should cover. And it really gives you sort of a roadmap of I gotta move this thing out my way, a roadmap of how to approach different topic areas for adolescents. And so traditionally included as HEADS, and has really been expanded to include not only home education, but also eating, activity, employment. We typically think about drugs and suicidality and sexuality and sex, but also including safety and gender identity. But I think what's really critical is to really go beyond just checking the boxes. So this is not necessarily to be a question answer type of approach, but more to actually build rapport and to gain the adolescent's trust. It's because school health clinicians are actually one of the few allies that students may have, right? So a lot of these youth may only have you as an ally. And so this is really an opportunity to understand the youth's needs, to really engage them around their psychosocial history, and to develop a rapport with that adolescent so that they're open and they're willing to share information and ask questions. Also, it's important not to assume anything. No assumptions. So don't assume heterosexuality or gender identity. You ask about gender. Ask about the gender of their sexual partners. Don't assume that they're binary, right? So asking about the sexual partners that they're having, asking about romantic relationships. I often will ask questions about romantic relationships separately from sexual activity, because a lot of adolescents get the two and they keep them separate in their mind. So really asking about these topics in a thoughtful manner. Providers can use forms that can actually help to start the conversation, but when using the, it's important to not to present questions in a gendered way or a heterosexual approach. So really not having any assumed statements about one's sexual orientation or gender identity on those forms. So it's really important to think about that in a critical manner. And then having educational materials that speaks to all religious groups, all sexual orientation groups, all individuals, so that the space is all welcoming. So let's go through some basics. A lot of this you've already heard from Molly, but we'll talk about how we talk about this in the context of a visit. So what is sexuality? So sexuality is a noun. This is as defined by Oxford Dictionary. It's the capacity for sexual feelings. And really, it's more than just the capacity for feelings, but also includes aspects of one's sexual orientation. And so I think that when you think about sexuality, you have to also think about sexual orientation, which includes multiple components, which we'll talk about in a second. But when you think about sexuality, think about it as not necessarily a linear relationship. For adolescents, it's a key part of their adolescent development. It's a key part of figuring out who they are. And while we often like to think of sexual identity as a linear line, it's often much more complicated than that. And so that's why I really like this picture here that really shows the more accurate representation of what sexuality is. And it can change over time and be constant, but also be fluid. And so being open to that is really important. And so this is just a visualization of what sexuality being on a continuum looks like. Oh, I did want to point out one thing. Individuals often conflate sexuality with sexual orientation, and they're not necessarily synonymous. In thinking about sexual orientation, you really have to understand that there are three components of sexual orientation. That's the attraction, behavior, and sexual identity. And I like these overlapping, but not completely overlapping circles because they don't always match up, right? So someone's sexual attraction, like our patient that we started with, may be to someone of the same gender, but their behavior may be opposite of that, right? So, and that's normal. And so really trying to think about this and this approach allows you to ask questions that are in line with these different areas. So attraction really speaks to that enduring pattern of romantic feelings, and behavior is the sexual activity, and identity is the larger concept of who the person is, and it includes aspects of attraction and behavior, but it's also part of the larger affiliation of that individual. I did want to just bring up the Kinsey's continuum of sexual orientation, and because I think it's really important to demonstrate that sexual orientation and sexual behavior exists on a continuum. And so it's not just black and white. We often like to put people into two different groups, and it's much more of a continuum, and there's much more of this gray area don't like to think about people being in. So it's really important to ask these questions because individuals may exist right in the middle and may not necessarily identify as bisexual, right? And really, the recent data from the Gallup poll in 2017 has demonstrated that about 4.5% of the population identify as LGBT, but many more persons describe having experienced same-sex sexual behavior or same-sex sexual attraction. So just because someone engages in same-sex sexual behavior or attraction, don't assume that they're gay and don't assume that they're straight, right? So you really have to unpack and ask those questions to the students and the adolescents that you're seeing to really understand what that means for them, because every person's different. So gender, Molly talked about this already, but really is socially constructed based on roles and behaviors of what we assume in society one's gender role should be. And gender identity really speaks to how individuals identify as a male or female or non-binary person. And so these are the dimensions of gender here. And expression is very different from gender identity, right? So the natal sex circle, or the sex assigned at birth, which is the preferred term, refers to the gender assignment at birth, whereas the gender identity is how a person identifies it. So it's that a person's basic sense of being male, female, or non-binary or another gender. And expression could be completely congruent or completely incongruent with that. And so one really key concept that I hear people do all the time, a lot of people conflate gender identity with sexual orientation. And those are two different concepts. So who you are as a person is completely different from who you are from a sexual perspective, who you are as far as who you identify as and who you're attracted to. Okay, so really practical approaches here. So intake forms can be used to routinely ask about questions around sexual orientation and gender identity, and they should be asked separately from behavior. So not including a section around sexual behavior and then putting gender identity in there and sexual orientation, because sexual orientation really speaks to who the person is, right? And not necessarily to the behavior itself per se, right? They may be related, they may not for sexual orientation. There are very few evidence-based approaches to asking SOGI in adolescents and children. We use a lot of our approaches based on adult data, so I'm going to go over what that looks like. So there's been some good work in this area, particularly by the Fenway Institute. And so really assessing sexual orientation using a one-step method to describe how individuals think of themselves and giving options. This is just one example of. The preferred method for gender identity is really a two-step approach. Asking about current gender identity first, and then asking about the sex assigned at birth. And then giving options that are representative of multiple gender identities, including gender fluidity options. And so this is a better approach than just asking someone, are you transgender, right? So you can see how asking a question like, are you transgender, might be confusing to people. When I hear from youth all the time that they didn't know that term, even if they identified as trans, until they talked to other people, until they saw resources, until they started to ask questions and do some learning and some introspection on their own, and looking into resources. And so for someone who may not have heard of those terms, it may actually not be reflective of them. And then some individuals don't necessarily identify as trans, right? So or transgender. So some may identify as male or female. You know, those individuals, by just asking a question, are you transgender, they may not be reflected or captured well. You know, I hear from providers, oh, I don't want to ask because I'm worried that if I do ask, then individuals will not want to tell, or they'll feel uncomfortable, or they won't view this as part of their regular medical history or medical care. The equality study, which was between here at Johns Hopkins and in Boston at Harvard, was to really ask these questions in a routine manner in the emergency department. And overwhelmingly, individuals were comfortable providing information about SOGIs, sexual orientation and gender identity, routinely. And they viewed it as something that was necessary, should be necessarily collected as part of their routine medical history. So what I would say is that, just to encourage you to make it routine. This is one evidence that demonstrates how important it is just to make it routine in our clinical care and clinical context. And providers also viewed that it was important. So both patients and providers in this study viewed that SOGI collection, routine SOGI collection, was really important. Now, sexual behavior. How do I ask about sexual behavior? The Centers for Disease Control and Prevention recommend the use of 5 Ps. So partners, practices, protection from STIs, past history of STIs, prevention of pregnancy. And I always like to add another P. I've seen other people do it as well, for pleasure as well as performance. Very key areas that are important to ask. So intake forms, again, can be very helpful, but this is also an opportunity to just talk, one-on-one with people around their partners and around their sexual history and around their relationships. You might want to start with a question like, are you in a relationship? Just to ease into the discussion, asking about, are you attracted to males, females, both, neither, non-binary. Have you ever been intimate with someone? And give examples. Depending on the age of the adolescent, it may be helpful to really give examples of what that means. And for some younger adolescents, it may be that they haven't engaged in, vaginal sex or anal sex, but they may be doing digital sex, or they may be engaging in other types of sex. So asking about those types of sex that they've had and asking about other aspects of intimacy. And then making sure that you're aware of your own personal body language. So it's really important to check your body language, be aware of the wide range of behaviors that exist, and be open and remain neutral when people describe that. So, here's some good examples of how not to look, right? So no wrinkling of the face. No, we don't want any of that. That's not appropriate, right? So just being open, taking deep breaths, long pauses, creating a really open and affirming space and non-stigmatizing environment. The third step is really to assure confidentiality. So there's been very good data that demonstrates that youth are less willing to share information about their sexual history and reproductive health, as well as gender identity, if it's unclear that their confidentiality will not be maintained. And so, sort of giving this picture of, well, I may or may not be able to share your information, or I may or may not be able to protect your information, is not what the adolescent wants to hear. It's really important to know your local laws, and we'll talk about that in a few minutes. But most jurisdictions do ensure some level of confidentiality when in adolescent care. And so the requirement of parental consent is a barrier to receipt of confidential services, not only for adolescents that are 18 years and younger, but also for adolescents that are 18 years and older, just because of concerns about insurance and the explanation of benefits. We found that it's been a barrier to exposure prophylaxis or PrEP. And so this is a visualization. This is from the Guttmacher Institute, and I think I've mentioned this as a resource, but really shows the minor's capacity to access STI and HIV services without parental consent. And what you can see is that there's variation across the country. So there are some states that STI services and HIV, so that STIs are defined, HIV is defined as part of a statute or regulation to provide capacity consent without parental consent. And some states, particularly in Maryland, as you see here in blue, where it's not explicit. So it's not explicitly defined. HIV is not explicitly defined, but it's defined by implication as part of all STIs. So some states have explicit information around HIV and other states don't. That doesn't prevent us from providing care to adolescents without parental consent, but it does help us to recognize where our protections are. Okay, and so I think the Guttmacher Institute is really a good resource to be able to, and the CDC, to really be able to go and look to see in your state, in your local area, what minors can consent to without parental consent. This slide shows HIV preventive services, which is actually a different a level of protection, especially when you're thinking about pre-exposure prophylaxis. And I think that this actually, this map is not completely up to date, because Maryland now allows for just recently passed access to preventive services without parental consent, as does, I think, New York, and there's someplace else that I'm thinking of. So really trying to figure out, sometimes it takes even just looking at your local laws to figure out, you know, so there's the one level of access to STI treatment and prevention. And then some states, as shown here, have additional protections when seeking preventive services for HIV. And that's where the protection or pre-exposure prophylaxis falls in. And let me just say one other thing around that. You can, so there's some flexibility in the language around prevention of sexually transmitted infections, which allows you to be able to provide access to pre-exposure prophylaxis and other preventive methods without having an explicit preventive minor consent law. And so you would never only treat the STD, for example, and not give condoms. So even if the law is explicit around STDs treatment, prevention often goes with the treatment, because you're trying to prevent that STD in the future. And happy to take questions there at the end. The other thing to think about is really around explanation of benefits and insurance. So, you know, this is really important, because it's really important, and you sort of start to get into the weeds. But really, you know, you can have protections in place in your state around seeking services, and then an explanation of benefit, which is the description of the service that's been provided, goes home to the parent, and then that actually outs or discloses information around what the adolescent has received. And so, again, on the Guttmacher website, you can see which state provides what protections to dependents. And this is regardless of age. You know, the insurance now covers individuals up to 26 years old. And so 5 states allow for confidential communications with the insurer dependent. So they allow those communications go directly to the dependent. 2 states have explicit projections around explanation of benefits. And then these 6 states explicitly provide confidentiality around care provided under insurance. So there's additional protections from an insurance perspective around confidentiality and access to services for minors. But they're all a little bit different. So it's really helpful to go to that link there to be able to see what is in place, so that you can actually counsel the adolescent to really discuss what is realistic, and so that they're aware of what is going to come home and what's going to be shared with their parents from an insurance perspective. I would say also that some local jurisdictions have Title X clinics that provide free or reduced cost care confidentially without parental consent. And that allows for adolescents, at least it does here, to be seen without worry of anything going home on their parents' insurance. And then local health departments can also be a very great resource for confidential services. So it's really also important to, be aware of the social context of adolescents. So adolescents are in school every year, most of their life. And so it's an opportunity, and sometimes it can be a missed opportunity if we don't take advantage of it, because it's a really an important opportunity to connect with youth and to provide development appropriate sexual health information. And this may be their only place where they're getting it, with you one-on-one. But in schools, many youth also miss schools because they don't feel safe. So this is data from the GLSEN 2017 climate survey, and 34.9% of youth had missed more than one day of school in the past month because they felt unsafe or uncomfortable due to their sexual orientation or gender identity. And that's shown here. So this is really, they subsequently asked individuals why they had missed school and for what reason. And what you can see is predominantly because of sexual orientation, gender identity. There were other areas that did also come up consistently, such as body size, gender, and also religion and race. And so what's really important to think about when you're seeing youth is that a lot of youth actually experience discrimination in the school because of their sexual orientation. This just demonstrates that in this survey, what they found was that pansexual youth were more likely to describe experiencing discrimination than any other group on the survey. And so, some youth that you may not view or see as vulnerable may be quite vulnerable to risk in the school environment and outside the school environment. So it's really great. It's really great to engage and to ask. 9 of 10 LGBTQ students being victimized at school, and most often because of sexual orientation or gender expression. Over half of them had never reported it. And when asked why they had never reported it, they really felt like they did not feel that there was going to be an effective intervention if they did report it. So most described not reporting it because they didn't feel like the staff would be able to do anything. So 68% did not think that the school staff would do anything, and 61% felt that they wouldn't be effective in handling the situation. So really feeling vulnerable and isolated and not reporting risks for bullying, but also feeling like even if they did report it, not feeling like they'd have access to anyone who would be able to do anything to make a change. There are a lot of reasons why youth in the school environment experience trauma and isolation, and stigma is one of them. And so stigma is really the labeling, stereotyping, separation, discrimination of individuals based on social status, characteristics, sexual orientation, such as sexual orientation, gender identity, race, ethnicity, disability, HIV status, body size, etc. And you can see that in what was just demonstrated from the GLSEN 2017 data. I really like this here from Irving Goffman. And so really Goffman's theory of social stigma is that it's an attribute, behavior, or reputation which is socially discrediting in a particular way. It causes an individual to be mentally classified by others as undesirable, rejected, rather than accepted or normal. And so that's what stigma does. It isolates individuals from other people and puts them at risk for vulnerable, makes them vulnerable and puts them at risk for poor health outcomes. Minority stress is also really important to think about. And so I really appreciate this picture that I found on Google. I can't tell you who the author is of the picture, but really school is supposed to be a safe space. And for a lot of sexual and gender minority youth, it's really not. And they experience a lot of stress in that environment, and that can actually impact their mental and physical health, and individuals may present to you because of that. It may be complaining of headaches when really there are other factors that are contributing. There's also racism related stress. And so there's been some good work by the HRC, just really looking at sort of the pervasive historical discrimination and stigma around multiple parts of one's identity. And so it's really important to think about how race may contribute to the burden, how youth that are of color may experience microaggressions, both in and outside the LGBT community. It sort of the lack of community that exists for them. And HRC found that racism-related stress was very common among LGBTQ of color. So really thinking about not only minority stress, and but also thinking about how the microaggressions that youth of color experience that contribute to vulnerability and poor outcomes, but this intersection of identities that exist. So we often just group people into one circle and not really thinking about how these identities intersect to create a specific vulnerability right in the middle. But this is also where protective factors can really be helpful to youth. So I have about 15 more minutes. I'm going to go through what you can do in your setting and thinking about what we just talked about and some practical steps, and then we can open the discussion. So I think really being aware of resources that are available to you. I know I've heard on the prior sessions, people have said that they don't have a lot of resources, and that they some places feel pretty isolating. I think that there are some available resources online that can be useful. So one, looking in your local community, but also looking at GLSEN. GLSEN has a safe space kit that's really, really wonderful, and really has some really concrete strategies that can help support students really in multiple areas in school environments. And it also helps to be able to demonstrate that what to take to your school to demonstrate the need for intervention in this area. And Advocates for Youth also has a lot of information about health and advocacy and resources that can be used for adolescents. I think empowerment is really important. So gay straight alliances have been demonstrated to result in lasting effective change. And so they not only have been shown to address the needs of LGBTQ students, but also to address the needs of larger students in the overall population, and to address safety as well. And so GLSEN, as well as Advocates, has really practical tools that can be used to actually start groups, advocacy groups that help youth to organize. And organizing youth, or empowering youth to organize themselves, actually can improve their own health outcomes. So there's been, and I'll show you this in a few minutes, but really lasting change as a result of them. Comprehensive sexual education is really also critical. A lot of states don't require sexual education, and a lot of states don't require HIV education, right? And so what you can see here is that the really the states shown in red that actually don't require sex ed or HIV education. In some states actually prohibit the use of using specific terms or terminology, or prohibit the use of talking about same-sex sexual education in their environments. And so really trying to advocate for comprehensive sexual education is really helpful to youth overall. And when asked, so here's some good data. When asked, 80% of Americans support teaching comprehensive sex ed in high school and middle school. And so, I think a lot of parents believe that their youth are getting that. They don't realize that the education that's provided in the school setting is not comprehensive, but it is often abstinence-based. And we looked at this in the YRBS data and found that particularly young men who reported prior sex with other men, they were less likely than their heterosexual peers to actually have received appropriate education. So even when it's provided, LGBT youth may be less likely to receive appropriate education. And this is what's shown here also from the GLSEN 2017 survey that really, over 43% of students had received no education or had received education without specific topics. So really more than that, almost 80%. One approach is really to address the overall policies. So policies that focus on anti-bullying and harassment may improve overall policies for all students. And so trying to use sort of the approach of making the entire school environment safe and trying to enact bullying and harassment policies may actually help to address some of the needs of the sexual and gender minority students by creating an overall inclusive environment for all persons. And here's evidence. So here, this is just looking at the GLSEN data over time. And what they found is that having access to GSAs, curricular resources, as well as educators and inclusive policies really did help to decrease the proportion of individuals or the rates of what was described as individuals describing homophobic remarks, youth describing the proportion of students that describe feeling unsafe, as well as decreasing the rates of anti-LGBTQ victimization. And staff were more likely to describe that they had received some improved ability to not use biased language. And what happened over time is that youth were less likely to miss school and had higher educational and academic achievements. And so what you can often use is the goal of any school is for their students to actually achieve educationally. And so when you can show that GSAs actually help students to reach academic achievement and overall aspirations and perform better, school administrators may be more willing to support such strategies. And this is just a visualization of how the proportion of resources over time that when surveyed, teachers and staff or more supportive of resources, that there's been an increase in the number of GSAs. There has not been as much policy changes, I think, as people would like to have seen. And there hasn't been as much comprehensive anti-bullying policy over time. But these are two areas, well, all of these areas are areas of need, but you can see how this has just really improved over time. And that's where they're seeing that the academic achievement has improved as a result of it. So this is my last slide. So I think, just to summarize, schools are a really critical environment where youth really need safe spaces, because youth are vulnerable for multiple reasons. And as a school-based health provider, I think this is a real opportunity to create a space for youth. This talk was really meant to provide examples of how to do that. And I think trying to make a welcoming environment, using non-judgmental language, promoting confidentiality, and really embracing and understanding vulnerabilities of adolescents, including their intersecting identities and risk, and will help you to really improve the lives of the youth that you care for, as well as change the school environment and empower the youth. Those are just practical examples of how to make that difference where you are. All right, I'll take questions. Do you want me to turn it back over to you?
No, you can take questions for right now, and if anyone wants to refer to one of your slides, you can keep control for now.
Okay. Were you able to hear me okay?
Yeah. Yeah.
Okay.
So,
Renita, I have a question, if I may.
Sure.
And it kind of came up last week with my social worker and I. A mother and her child came to us, and the child is now saying that he is transgender. He is 18, but that he has just come to this in the last, maybe 6 months after talking to somebody online. Having some comfortability with me, he was, acknowledging that actually he does online school, so he's not in the school system. And, some acknowledgement of uncomfortability with bathrooms and whatnot. And so really began to become comfortable with me. So at this point, I guess my question to you is this, sometimes it seems like there might be some confusion. Could this possibly be, and we've even heard about this in some other cases in Texas, where people have gone through the complete transgender operation and then realized this wasn't the right choices for them. The last thing I want to do is refer him to, injections or movement in that direction if it's not right. And so I spoke with my social worker, is there any tools? Is there any assessments? What can we do for providers out there when, because sometimes kids just know right from the get-go. I've always, said I was a male. I feel like I'm a male, but then there's this, so this child didn't have that initially, it just kind of grew into it. And could this be a fad where you don't want to do an operation and do all of that, or let time go? What would be your recommendation to us as providers because it's new to us too, to how to navigate through some questions, or I don't know, it's just something that really hit this week.
Yeah, I think that's a great question. I think that you're also describing a lot of what parents worry about, right? And so what I'll often talk to parents about is that, it's really important to first create and provide a safe space for the youth to feel open in sharing their thoughts and their identity with you. I think the role of the provider is really to help unpack that for the adolescent. And, no one just jumps directly to surgery, first of all, right? So it's not like on day one you say that you just are now trans, and then day two you're going to get surgery. It doesn't work like that, right? So it's really an opportunity to provide an interdisciplinary team approach. So, if possible, to connect them to a psychologist, a therapist that can spend some time, unpacking this with them, so they really understand for themselves what that means. I often give workbooks around gender identity because it's a self reflection. It's really about themselves, right? It's not anyone else's decision. Really having resources. So what I would say is to connect them with a psychologist practically. It's good that your social worker or therapist is working with them, but to spend some time so that they can help to figure this out for themselves. And if it's been, what we find is that often people have delayed telling people until late because they're uncertain how people are going to respond, right? And so it may be that they are only now saying this, but the feeling has been going on, the sense has been going on for much longer. But they've been very concerned about sharing it openly and waiting for the right time to do so. So this concept of, oh, this just happened is not often, because for a lot of people, it's been a sense that they've had for a long time, and they just haven't been able to put words to it. And they haven't had the space to do it. So by linking them to a psychology therapist and doing a really interdisciplinary approach, you provide supportive treatment to the adolescent and their family, and you do it in a thoughtful manner that's not necessarily isolating or devaluing, or because you really want to tell that adolescent that you see them, you hear them, you accept them for who they are, and so that's very critical, and not necessarily saying the opposite. Does that make sense? Does that help?
It does. I liked the component you said about the workbooks, because even the social worker was like, some of these things to help them define themselves. If you happen to know of any of that, I would greatly appreciate that.
Sure. I'll write myself a note. Do others have thoughts?
Renata, I have a question, but it's sort of for the group. In some of the things that you mentioned around school policies, around bullying, whether there's a GSA, and I'm wondering if any providers on the call, if your school-based health center, if you have experience with connecting the school-based health center staff to some of those larger policies and activities that are happening in the broader school setting, if you're involved in the bullying policies and the GSA, and because I think what often happens is that, and I think we heard a little bit about this on last month's case discussion, that in some cases the schools do have these things, but the school-based healthcare providers are not involved at all. It's just, there's just kind of a separation. So I'm wondering if some providers on the call have experience of kind of bridging those two. And I think something that we've seen that is instrumental in making that connection is whether the school-based health center has a youth advisory council, because they can often be the bridge with students in the school and the GSA and a lot of those bullying policies and other activities. So I just thought it would be interesting to hear from folks if you all have some examples to share about how that's working. Does anyone have any? Or if you want to share how it's not working, and we can try and help with that. Michael, you're muted, Michael. Hold on, we're trying to get you connected here. Yeah, is the audio through your computer, or have you called in separately? Do you want to call in separately? Because we can't hear you. Okay.
Do other people have GSAs at their school, and if so, how's that gone? If not, is that something that you're interested in hearing about, or like you could benefit from?
Hi, can you guys hear me now?
Yes.
Yes.
Oh, great. Did I interrupt anyone? Sorry.
No.
So I don't necessarily have an example of it working well, but I actually can touch on a little bit of the challenges of initiating some of that work, because I agree. I think that having a youth advisory council would be very helpful, and that really is the most logical way to bridge into the schools. But I've been with our organization for about a year now, and one thing that I've noticed is quite difficult in establishing some of these really good relationships is just the fact that everyone always seems so busy to be doing anything extra. And so many of our school health employees, they work hourly, and so going above and beyond sometimes can be quite challenging. And then same with the staff members in the school are different, like health information project coordinators, they're very, very busy individuals. So I've been working the last year trying to build some of those relationships, but it just hasn't stuck yet. And so and even with students, there's student turnover, and a lot of the student leaders that we get in our clinics maybe are juniors or seniors in the high school, and so when they turn over, it's kind of reinventing the wheel when those seniors graduate. So I don't know, I'm looking for any tips that people do have, but I've definitely seen more the challenging side of really engaging and becoming more integrated into the school in that capacity, if that makes sense.
Have support from your administration?
But by our administration, do you mean the administration of the schools that we work in, or at the University of Miami?
At the schools that you work in.
We get all the support in the world from the schools we work in, but again, they're so focused on their students passing Algebra 1 or learning English to be able to take their standardized tests that a lot of times some of these other initiatives they don't become quite as engaged in, and they don't take as much leadership, and they kind of turn to us to say, oh, like, you guys need to do all of it. And so we get support from them, but a little less on the action side of things.
I see. Is there any way that it could be, because it sounds like you're getting seniors, but is there any way that you could try to see if the school will support you get freshmen, early on when they start high school rather than later?
Yeah, we're working on that. So I've connected with a couple of patients that have come through our clinic, because we do get a lot of freshmen that come in for sports physicals and things like that. And so I try to gauge interest in a little bit of leadership just during those very short visits that I have with some of our patients. But I think that there's something deeper that's missing, whether it's still the cultural feel of the school and the clinic working together. Because we have so many different clinics, it's not as possible for me to really be present at all of them at all times. And so trying to empower and engage, I think, more staff members is something that I'm looking for a little bit of guidance on as well. Because many times it's sort of left up to our nursing staff, who interacts with the students on a much more regular basis than I might do myself, or our residents who rotate with us just for 1 month at a time. And so just, I think, looking for trying to build sustainability within the school is sort of what I've run into. We get in little pieces of motivation here and there, but there hasn't been anything that's really quite stuck on that people have committed to yet.
I'm wondering if this is Molly. My computer's doing a mandated upgrade, so I can't see anything, but I think I'm unmuted. Is that right?
Yes, we can hear you.
Okay, so I'm wondering, I work at a hospital, so I'm not in the schools, but I have contact with nurse practitioners that are, and I'm wondering if there's any way that, like, I know some high schools have like a mandatory, like, you have to do so many community service hours before you graduate. I'm wondering if there's any way that, like, if that is something that's going on, if like being part of a GSA could count towards community service hours, just so it is like counting towards, all of the standards that young people in high school have to meet. And then on the flip side of that, if teachers need, I'm assuming they need continuing education to keep their license up, if they could, have continuing education credits for, being, taking on a leadership role for, the GSA or LGBT kids in the schools. I'm just throwing that out there. I don't know if that's a possibility at all.
Yeah, our schools definitely require the students to do some sort of community service. So I can brainstorm on some of that and take it back to my team members and see what we might be able to do. Particularly with our mental health team, we have a clinical psychologist and an LCSW who does some mental health counseling as well. I think that they're very interested in this topic and helping to build some of those closer integrated relationships with the student groups in the schools.
And I was just going to say, I can't speak for the teachers in terms of CEs or community service credit, but I know that a lot of the school-based health centers that have youth advisory councils, I think a lot of them do offer some sort of school credit or community service credit for them to be part of that and taking a leadership role. I also wanted to mention, and I'll send this out, but we have a number of resources at the Alliance on youth engagement, as well as specifically tools on how to start a youth advisory council in your SBHC. So I will make sure to send those out.
I'll also add that, can you hear me?
Yep.
I'm from the Adolescent Health Initiative, and we also have some resources I can share with you, Suzanne, that you could also potentially share. But I think a challenge is, as you said, having somebody that can take leadership and own the project of shepherding the youth advisory council. But I do think if you can find someone that can be that champion, youth advisory councils are the times I've seen them be the most successful is not only somebody that's kind of owning and championing that, but someone that is able to really invest in being really planful and like really planning agendas and projects and putting the footwork into making it a worthwhile space and time commitment for young people. Because if it feels just kind of like another meeting you're going to and there isn't structure or a real clear plan for the year or even for the meeting, that's a quick way to lose engagement.
Yeah, I was just gonna say the same thing, that I think our youth advisor council has been more successful in the last 2 years because one, we had a little bit of an application process, right? So people had to write why they wanted to be a part of it. And then they really tried to identify goals that they want to accomplish, as well as change they want to see made in their community or in their school. And then we, combine that with fun activities, but it's really centered around like doing community service, making a change, making a difference, so that they feel empowered to do things and they are at the table making those decisions rather than someone telling them the reverse of what they should be doing. So I think just trying to engage them, I think that then you will also be able to demonstrate to the school that they are, it is a leadership activity, it is a leadership responsibility, and it does come with community service and community service hours that are required.
Anyone else have any thoughts or questions?
Suzanne, I texted you a link to the Gender Quest workbook that we use in the trans clinic here. If you want to send that out to people, it's kind of a self-guided workbook.
I will. And if anyone else has any other resources that you want to throw into that, just type them in the chat box and I will send a follow-up email on Moodle with all the resources consolidated so everyone has that. All right. Well, thank you so much, Renata. That was great. So we are going to move on to our case presentation for today. So Maureen Murphy from River Rouge, Michigan